Hello, I'm Cennet Kurtev with the Power of the Patient Project. My guest today is Dr. Mitchell Brotsky, DPT. Dr. Brotsky is a physical therapist working in the suburbs surrounding 5 counties in Philadelphia, PA. He graduated from Arcadia University in 2014 with a Bachelor in Healthcare Administration and received his doctorate in physical therapy in 2017, also from Arcadia University. Mitchell is currently a lead therapist at Premier Home Care Inc. and serves as their compliance officer. Mitchell is also part owner of a non-skilled agency, Premier Companion Care Services, which is a sister company of Premier Home Care. Mitchell specializes in geriatric physical therapy with predominant focus on post-orthopedic rehabilitation, such as knee and hip replacements, spinal fusions, and post-fall fracture rehabilitation. Welcome, Mitchell.
Thank you very much for having me.
In your opinion, what are the most important things that a physical therapist can do during a session to ensure that a patient's rights and dignity of the patients are ensured?
So I always believe that you need to be a person first and a clinician second. If you look at every person as only a patient and you only see them as a series of data and trends and potential outcomes, you never connect with a person. And in that case, you don't really respect their rights and dignity as a person. You kind of tend to overlook that things. Bedside manner is a huge portion of this, especially I believe in the rehabilitative medicine spectrum. You want to always establish a personal connection first and foremost with all of your clients. Of course, you should treat them as patients. You should always be mindful of their outcomes and of the potential, resource that you have to benefit them. But you should never forget that you are a person just like them. They have the same kind of thought process as you do. They may have certain fears. They may have certain inquiries. If this is a new procedure for them, if this is a new experience for them, they're going to be, apprehensive. They're going to have questions. Don't overlook those things. Bedside manner goes a huge way, especially in this field. I believe that you need to specifically tailor your interventions as well towards as a client. A really good example of this would be if I have a person who is very nervous about doing a certain specific set of exercises or learning a new task or something like that. You then need to curtail your approach in order to best, serve them as well, right? You don't want to push somebody into something that they're not very comfortable with. You want to respect them and their rights to say no and yes. So you need to kind of work with the person in that aspect and, tailor your approach to what works best for them while still attaining the same goal.
Okay. Well, for our second question, many of us have experienced a rehab therapy session, and often we are treated in a large room with many tables where other patients are being treated by their therapist at the same time. How do you honor a patient's request to protect their modesty while everyone else can see them?
So I'll answer that in two segments. I will give the direct approach, I guess, to that, and then I'll give my personal opinion and my personal approach to that. So yes, in a lot of ways, physical therapy is a multi-person and multitasking field. So in the instances of skilled nursing facilities, inpatient rehabs, hospital rehabs, which would be in like an acute setting, and outpatient is very predominantly heavy in multitasking and having multiple patients. You need to, again, approach this with the idea of being a person first and having the appropriate bedside manner in that aspect. So the best way that I could explain that would be, if you're a new person in a clinic, right? The chances are that you're walking into a clinic where the therapists know each other very well. They're communicating, they're probably on a friendly basis, and in all aspects, the rehab center of whatever you're in, so whether you're in the hospital, the inpatient, the skilled nurse facility, the outpatient, whatever, they always try to keep at least some kind of friendly atmosphere and camaraderie between the therapists. It's critically important for the therapist to involve the patients inside that circle and make them feel comfortable in that aspect, right? So if you feel like an outsider inside that outpatient setting, right? So if you're not talking to people, if you don't really have a good relationship with your therapist, if you don't feel comfortable in that setting, you won't really have that comfort to be there. And in a lot of ways, that modesty that you're talking about is going right out the window, right? So a lot of those things can be curtailed by simply creating an inclusive environment. You can include them in conversation. You can ask them how their day is going. You can ask them about their weekend plans. You can do a lot of those things, right? Those are all great approaches to creating a personal connection with a client and a patient so that they feel more comfortable in your clinic, regardless of what that setting is. That's a big one. Just keeping a good, consistent, friendly atmosphere that the person feels safe. Now, in terms of other modesties, obviously, you have to respect, certain conditions and certain time frames will dictate that you take the person into another area, right? So a really good example of this is women's health physical therapy, right? So a lot of physical therapy clinics will offer women's health. Now, obviously, you're not going to do a women's health exam in the middle of an open floor. That's just that would completely be inappropriate. So in that aspect, you need to learn how to juggle with your coworkers of, hey, listen, I need to do this pelvic floor exam. We're going into this closed room. I need you to do X, Y, and Z, right? You will utilize either a physical therapy aide, I'm sorry, not an aide, a physical therapy assistant, a PTA, or you can use an aide to do like the more, to do the non-hands-on tasks. So it's going to be stuff like, hey, can you prep this room for the next one? Can you wipe down these, stations? And then communicate with a PTA or another fellow PT if you don't have a PTA, and let them know, listen, I need to take this client into this private room. Can you handle this, this, and this, right? So you need to learn how to juggle that. When applicable, you should try to perform most of your day-to-day routines in the outward settings so that you are including the patient. Direct consultations, initial examinations, those kinds of things are usually done in a closed room. Your schedule should reflect that, meaning that you should be allotted time in your clinical rotation to take on that initial examination. So for instance, in an outpatient setting, if your schedule is one patient every half hour, you will then block off an extra hour during the day to take in an initial examination so that you have that one-on-one time to connect and establish that connection with the patient. And then you can, of course, respect their modesty needs and things like that. Like I said, women's health is a really big prevalent one with that. If you have if you have any kind of other situation where you would need a person to be in a private room with yourself, that's when you would utilize that. So those are great ways. But like I said, the biggest thing is, inclusivity inside that therapy community, because that's essentially what you're establishing as a therapeutic community. Now, on a personal level, I'll answer that as well. So I do home care because I believe in one-on-one physical therapy with clients. I 100% acknowledge that outpatient has its role in the rehabilitative medicine practice, right? And a lot of things that you would need to accomplish in outpatient, you can't accomplish in home care. But the reason that I do home care is because I find it easier to connect with people, especially because you're on their playing field, right? So they're no longer in a clinic where they feel out of place. You're in their home, and the roles are reversed big time, because now you are on their playing field. You have to feel comfortable in their home and learn how to live by essentially their rules, right? But I'd rather put that burden on myself because I feel like I'm better able to accept that challenge, handle it, and it puts the patient at a more comfortable state of mind, right? So their apprehensions tend to go down about their medical condition when somebody's visiting them in their home. They feel like they're in their comfortable zone. And then you can tailor your interventions based off of what is available in their home. Like I said, outpatient has a huge role in rehabilitative medicine. It's absolutely critical and crucial. For myself, I just like to take that one step further and be directly interactive with a person in their own home, because I believe that a lot of the challenge that you may find in a crowded gym, you won't really find in the home setting. That's just on a personal level, and that's why I do home care rather than outpatient or acute care.
No, thank you for that. That was very insightful. I know you're also involved in home care, which you had previously explained. Explain to our audience the difference between an unskilled home health agency and a skilled home health agency and how that impacts the patient and their family when choosing a provider.
Sure, absolutely. So we can compartmentalize it into two segments, right? Like you said, there's the skilled side and the non-skilled side. So the skilled home health agency will encompass registered nurses, physical therapists, occupational therapists, speech therapists, and licensed clinical social workers. They are giving direct clinical intervention to the clients. So, nursing will do med management and wound care. Physical therapy will do, physical intervention as well. Occupational therapy, speech therapy, those are all direct interventions that are clinically guided. Each one of those people that's coming in through the skilled side is a clinician of some sort, right? Also, in the skilled side, you're directly utilizing a lot more insurance and compliance portions to it. So what that means is that, for instance, in the case of Medicare, you are directly relating all of your skilled interventions to Medicare. You are documenting it essentially and, proving your clinical need and aspects. There's a lot more regulation that goes in the skilled side. Compliance is a huge portion of it, right? And that takes up a good chunk of my day is ensuring that essentially everybody is within the Medicare guidelines and, performing what is not only applicable, but necessary. Versus the non-skilled side is going to be home health aides, CNAs. They are all going to be assisting with daily living tasks or ADLs, activities of daily living. Those are going to be things like bathing, grooming, changing linens, light housekeeping, essentially things that a caregiver could do for a loved one, but doesn't necessarily have the time or the ability to do that, right? So if you live out of state or you work a full-time job and you're not able to care for a loved one, that's when you would use a non-skilled agency. So, to give it into examples, a skilled need would be somebody who's coming home from a hospital after a hip replacement or a knee replacement, right? A home health aide could not guide them through that process of rehabilitation and recovery. But on the same side, let's say somebody is just elderly and needs help with bathing, grooming, dressing, the day-to-day activities and tasks. A physical therapist or a nurse wouldn't be going out there and, billing, an insurance agency for that because it's not a skilled clinical need. You would use a home health aide. Now, to not muddy the waters or anything, there is ways of obtaining a home health aide through insurance, primarily through long-term care insurance. But most of the time, the home health aides are there through private pay. Or in some extenuating circumstances through like the VA, the Veterans Association, the VA medical centers will, provide home health aides, but essentially they are paying out of pocket. It's not an insurance. It's not an insurance piece that they're utilizing like Medicare or Aetna or, Blue Cross Blue Shield. Most of the non-skilled side is going to be private pay or private pay from a separate entity who's providing those tasks. But the real question, that you should ask yourself in, selecting a provider is there a skilled need for a physical therapist or a nurse to be there? Meaning, is there some kind of wound or physical problem, something that a home health aide could not take care of because they are not clinically trained to do so? That's what you would, be looking at. So like I said, if you're, let's just put it for this way. If mom's coming home from the hospital with a hip replacement, you would absolutely be looking for a skilled home care agency. If mom just needs somebody to be with her, 4 or 5 hours a day while you're at work or unable to be there, then you would use a home health aide. Does that make sense?
It does. Thank you. Finally, can you give us some advice on how to pick the right rehab therapist?
The right rehab therapist? Mm-hmm. Yeah, absolutely. So I think this is a really underutilized portion of our healthcare system in general. For the most part, you don't always get to pick your therapist. And I don't know why that's such a hard topic, I guess, for people to consult on or for people to understand, is that you do want to pick a therapist that you get along with, right? And in the same way as you would go about dating, you kind of have to date your therapist, But a lot of times, you know, when you go to a outpatient physical therapy clinic, you just get set up with who's ever open, right? That's the very common way that it works. And in most settings, not just outpatient, you know, in the hospital, in, you know, even in home care, you're essentially getting sent whoever is available for that area. So, you know, the first and foremost thing is that when you are looking for a skilled provider, ask them who your therapist is going to be, right? Because 9 times out of 10, they already know who it is, right? So I cover a certain geographical location, right? For all of the clients that, you know, get opened in Bucks, Montgomery, and the main line, that's me, right? So for the most part, my agency knows exactly who's going to go out and see those clients. If you are a client and you're a patient who's looking for a rehab therapist, ask who your therapist is going to be. Ask what they're like. Ask what their patient track record is like, you know, and don't be afraid that on that first initial evaluation, when you do meet them, take a little bit of extra time, right? A lot of times I feel like patients are really pressured to just answer the clinical questions and then the therapist is out. Shouldn't work like that. And I'm a firm believer that you should take your time with every single patient, you know, regardless of what your time schedule is. Again, you're interacting with a person. You're not interacting with a data sheet. You're not interacting with just, you know, numbers on the board that are going to relate to certain clinical outcomes. It doesn't work like that. As a client, take your time, get to know your therapist on the initial examination and the evaluation. If you don't feel like that's a right match for you, ask for a change. Simple as that. And it's no fault of anybody's. It's, you know, it's not a personal attack, anything like that. You have to feel comfortable with your therapist in order to get the best possible outcomes. And that's been clinically proven that when a person feels more confident with their therapist, regardless of the therapist's skill, actually, you can have an underskilled therapist who doesn't know all the interventions, but is able to connect personally to a person and motivate them to do the things they need to do, versus a therapist who knows every single answer to the clinical spectrum, but cannot interwork their personality to match that person's. It has been clinically shown that those outcomes for the very skilled therapist with no personal interaction are actually drastically lower than the personable therapist. Right. And it's that, you know, it's not just anecdotal evidence. It's clinical, you know, clinically studied evidence that personality goes a long way in this field. So when you're looking for a rehab therapist, take the time to know them, you know, take that first hour examination and just, you know, see if that's a good match for you, if their style works for you. You know, if this is a person who over the next 6 to 12 weeks is, you know, coming to you 2 to 3 times a week, or vice versa, you coming to them 2 to 3 times a week, if that's going to work for you. There's a lot of time and a lot on the line at stake for you not to like that person that you're working with, you know, because that could mean the difference between your, you know, knee or hip working properly again, or you just grinning and bearing 12 weeks with a person that you don't really like, and then your hip doesn't really work the way that the surgeon intended it to. So that's a big thing, is just take the time, ask the personal questions, see if you can establish a personal relationship with that therapist. And if not, then no harm, no foul. Look for a different therapist as well.
It was very interesting. I believe most of our viewers will definitely appreciate hearing that. Well, thank you, Dr. Mitchell Brotsky, from all of us at the Power of the Patient Project.